Welcome to Brainstem Part 2, where we will dive into the midbrain or mesencephalon, a key region for USMLE Step 1. Let's break this down into its structures, cranial nerve nuclei, blood supply, and clinical relevance, everything you need to know for your exam. The midbrain is the most rostral part of the brainstem, sitting between the diencephalon above and pons below. For Step 1, you will need to know its major structures. Next, let's talk the cranial nerve nuclei, high yield for the exam. The midbrain is home to cranial nerve number 3 and 4. To recap, the midbrain is a small but critical region for Step 1. Knowing its structure, tectum, tegmentum, peduncles, its cranial nerves 3 and 4, and PCA blood supply and syndromes like Weber and Benedict is crucial in developing your understanding into the topic. Alright, let's dive into the midbrain, a high-yield topic for USMLE Step 1. This slide gives you a basic layout of the midbrain, also called the mesencephalon, and its major functions. Let's break it down into what you need to know for the exam. First, let's look at the midbrain's location and structure. The midbrain is the uppermost portion of the brainstem, sitting between the diencephalon. Here, you can think thalamus and hypothalamus, and the pons below. For Step 1, you need to know its origin of the cranial nerve 3 and 4. The oculomotor nerve, cranial nerve 3 controls most eye movements, pupil constrictions, and accommodation, while the trochlear nerve, which is the cranial nerve number 4, innervates the superior oblique muscles. A quick clinical cranial nerve 3 damage gives you a down and out eye, think Weber syndrome, while cranial nerve 4 damage causes the trouble looking down and in, like when walking downstairs. Now, let's talk major functions. There are 5 key roles to memorize. First, the midbrain relays information for hearing and vision via the superior and inferior colliculi in the tectum. The superior colliculus handles visual reflexes like orienting your eyes to the flash of light, while inferior colliculus processes auditory signals. These are often tested in questions about brainstem reflexes. Second, it controls eye movements via the oculomotor nerve. As we mentioned, the Edinger-Westphal nucleus, part of the cranial nerve 3 complex, also controls pupil constrictions. Think parasympathetic innervation. A lesion here can cause a fixed, dilated pupil, often seen in increased intracranial pressure scenarios on the exam. Third, muscle tone. The red nucleus in the midbrain tegmentum helps manage muscle tone and coordination, especially for the upper limbs. This ties into clinical syndromes like Benedict syndrome, where a midbrain lesion causes contralateral tremor due to red nucleus damage. Fourth, pain management. The periaqueductal gray, or PAG, in the midbrain is a big deal for Step 1. It releases endogenous opioids to modulate pain. Think of it as a brain's natural painkiller system. This is why the PAG is a target for pain control therapies, and it's often tested in questions about descending pain pathways. Finally, the midbrain regulates the sleep-wake cycle by communicating with the pineal gland, which produces melatonin. This connection ties into the reticular formation, which is another high-yield Step 1 topic for arousal and consciousness. For Step 1, always think of clinical correlations. Midbrain lesions can lead to syndromes like Weber or Benedict, which we will cover in more details later. But for now, remember, Weber involves cranial nerve 3 and corticospinal tracts. Think of ipsilateral eye issues, contralateral weakness, while Benedict hits the red nucleus, causing tremors. Also, the midbrain is supplied by posterior cerebral artery, so PCA stroke can cause these symptoms, another classical exam point. To sum up, the midbrain is a small but mighty region of Step 1. Know its role in vision, hearing, eye movements, muscle tone, pain modulation, and sleep regulations, and always connect it to the cranial nerve 3 and 4. On the next slide, we will dive deeper into midbrain structures like substantia nigra. Here you can think Parkinson's disease and add some practice questions to lock this in. Let's keep going. Let's dive into the midbrain's internal organization, a high-yield topic for USMLE Step 1. This slide breaks down the midbrain's key structures and zooms in on 2 critical areas, the crus cerebri and substantia nigra. The midbrain is divided into 6 main structures: the crus cerebri, substantia nigra, mesencephalic tegmentum, tectum, cerebral aqueduct, and periaqueductal gray. For Step 1, you need to know what each does and how they tie into clinical scenarios. First, the crus cerebri. This is the anterior portion of the cerebral peduncle and major motor pathway containing corticospinal and corticobulbar tracts. Think motor output from the cortex to the body and face. A lesion here, like in Weber syndrome, causes contralateral hemiparesis. You will often see this paired with an ipsilateral cranial nerve 3 palsy. Think down and out eye, ptosis, and mydriasis. Due to a posterior cerebral artery stroke. That's a classical step 1 question. Next, the substantia nigra. Huge for the exam. It's part of the basal ganglia and contains dopaminergic neurons that projects to the striatum to regulate movements. Degeneration of these neurons leads to Parkinson's disease, which you will recognize as resting tremor, rigidity, and bradykinesia. Step 1 loves to test this resting tremor with vignettes about dopamine depletion or Lewy bodies in the substantia nigra. Also know that the substantia nigra has two parts, the pars compacta, which makes dopamine, and the pars reticulata, which connects to the thalamus. For step 1, focus on the crus cerebri for motor deficits, the substantia nigra for Parkinson's, and know that the midbrain's role in syndrome like Weber and Benedict's. With the next slide, we will moving on to the other structures. Let's continue our midbrain breakdown for USMLE Step 1, focusing on mesencephalic tegmentum and tectum, two more high-yield areas you need to know. First, the mesencephalic tectum. This region contains several key structures. The red nucleus is a big one. It receives input from the cortex and cerebellum and facilitates flexor movements in the contralateral upper limb. For Step 1, think Benedict syndrome, a tegmentum lesion hitting the red nucleus causing contralateral tremor, often with cranial nerve 3 involvement. Think about the ipsilateral down and eye movement. Next, the oculomotor nucleus, origin of the cranial nerve 3. It controls most eye movements, pupil constriction, and accommodation via the Edinger-Westphal nucleus. A cranial nerve 3 lesion, like in Weber syndrome, gives you ptosis, mydriasis, and down and out eye, classical for the exam. The trochlear nerve nucleus for cranial nerve 4 is also here, innervating the superior oblique muscle. A cranial nerve 4 lesion causes trouble looking down and in. Patients, when they're looking down, going down the stairs and having a struggle with it. The tegmentum also contains the medial longitudinal fasciculus or MLF, which coordinates eye movements between cranial nerve 3, 4, and 6. A lesion here causes internuclear ophthalmoplegia. Think about multiple sclerosis, where the eyes can't adduct on lateral gaze. Now the tectum, dorsal midbrain. It contains the inferior colliculus, which processes auditory input and helps orient the head to the sound. Think about the reflex, head turning to the loud noise. The superior colliculus handles visual reflexes, orienting the head and eye to the visual stimuli, like tracking a moving object. A pretectal nucleus, also in the tectum, is key for the pupillary light reflex. Think about cranial nerve 3 pathway for pupil constrictions. For Step 1, know the tegmentum for cranial nerve 3 and 4, the red nucleus, and MLF. Think Weber, Benedict, or multiple sclerosis related eye issues. The tectum is all about the sensory reflexes. Next, we will cover the cerebral aqueduct and periaqueductal gray, plus some practice questions if possible. Let's keep going. Let's wrap up our midbrain internal organization for USMLE Step 1 with two final structures, the cerebral aqueduct and periaqueductal gray, both high yield for the exam. First, the cerebral aqueduct. This is a narrow channel connecting the third ventricle to the fourth ventricle, allowing CSF to flow between them. For Step 1, you need to know that a blockage here causes non-communicating hydrocephalus. Think about increasing the intracranial pressure, headache, vomiting, and papilledema. This can happen due to tumor like pineal gland mass or congenital stenosis, often tested in pediatric vignettes. Also, the aqueduct runs through the midbrain, so it's a landmark on cross-section, dorsal to the tegmentum, ventral to the tectum. Next, the periaqueductal gray or PAG. It is huge for Step 1. The PAG surrounds the cerebral aqueduct and is key for pain modulation. It releases endogenous opioids like enkephalins to activate descending pain pathways. Think inhibition of pain signals in the spinal cord. This is why the PAG is a target for pain therapies like deep brain stimulation. For the exam, know that the PAG also interacts with the raphe nuclei to modulate pain via serotonin. A classical question might ask about the PAG's role in the gate control therapy or theory of pain or its connection to the stress-induced analgesia. For step 1, remember, the cerebral aqueduct is about CSF flow. Blockage means hydrocephalus. The PAG is all about the pain modulations via opioids. Think about the descending pathways. Let's talk about the midbrain's blood supply, a high-yield topic for USMLE Step 1. Knowing the vascular anatomy here is key for understanding midbrain stroke syndrome, which are commonly tested. The midbrain gets its blood supply from the basilar artery and its branches. Let's break down the four major contributors. First, the posterior cerebral artery, or PCA, and its peduncular branch. The PCA is the primary supplier to the midbrain, especially the cerebral peduncles and tectum. A PCA occlusion can lead to Weber syndrome. Think about, again, ipsilateral cranial nerve 3 palsy with a down and out eye, plus contralateral hemiparesis due to corticospinal tract damage in the peduncles. That's a classic step 1 vignette. Second, the superior cerebellar artery. This artery supplies the dorsal midbrain, including parts of the tectum and tegmentum. It can also contribute to the blood supply of the superior colliculus, which handles visual reflexes. Third, the posterior choroidal artery, a branch of a PCA. This artery supplies the periaqueductal gray and hereby structures like the pineal gland regions as well. It's less commonly tested, but good to know for the questions about CSF flow or pain modulation. Finally, the interpeduncular branch of the basilar artery. These are small paramedian branches that supply the medial tegmentum, including the oculomotor nucleus and right nucleus. A basilar artery occlusion here can also contribute to a Weber or Benedict syndromes. Think again about cranial nerve 3 issues plus contralateral tremor if the red nucleus is involved. For step 1, focus on the PCA for Weber syndrome and the basilar branches for medial midbrain deficits. Know that midbrain strokes often present with cranial nerve 3 or 4 deficit plus motor or sensory issues. Let's wrap up our midbrain discussion with its clinical relevance. A critical topic for USMLE Step 1. The midbrain controls essential functions, so pathology here can have major impacts, and Step 1 loves to test this through clinical vignettes. First, the midbrain houses vital structures, and any pathology can drastically affect the body. For Step 1, think about strokes, tumors, or trauma. A posterior cerebral artery occlusion, for example, can lead to Weber syndrome, ipsilateral cranial nerve 3 palsy with a down and out eye, ptosis, mydriasis, plus contralateral hemiparesis from corticospinal tract damage in the cerebral peduncle. Another classic is a Benedict syndrome, where a tegmentum lesion hits the red nucleus and cranial nerve 3, causing ipsilateral cranial nerve 3 palsy and contralateral tremor. Midbrain damage causes problems with movement, vision, hearing, and memory. Movement issues tied to the substantia nigra. Then think about the Parkinson's disease with resting tremor, rigidity, and bradykinesia from dopamine depletion. Vision and hearing deficits come from the tectum, superior colliculus for visual reflexes, inferior colliculus for auditory one. A lesion here might impair reflex head turning to the stimuli. Memory isn't directly a midbrain function, but midbrain damage can indirectly affect the arousal and attention via their reticular formation, impacting memory processing. Weber syndrome overview. Let's dive into Weber syndrome, a classic midbrain stroke syndrome, also known as superior alternating hemiplegia. This condition hits the medial midbrain, involving key structures like oculomotor fascicles into the interpeduncular cisterns and cerebral peduncles. What's the result? An ipsilateral third nerve palsy. Think droopy eyelid and pupil issues, paired with contralateral hemiparesis or weakness on the opposite side. Why does this happen? The culprit is a stroke, typically from occlusion of the paramedian branches of the basilar bifurcation or posterior cerebral artery. These perforating arteries supply critical midbrain regions, and when they are blocked, the symptoms depend on what's damaged. This is a Step 1 favorite. Know the anatomy and the clinical picture. Now let's break down the structures involved and their effects. Perfect Step 1 territory. First up, substantia nigra. This area houses dopaminergic fibers that projects to the basal ganglia, influencing the ipsilateral motor field. Damage here leads to contralateral Parkinsonism. Think tremors or rigidity on the opposite side, because those fibers modulate movements across the body. Next, the corticospinal fibers. If only the lateral corticospinal tract is hit, you will see contralateral hemiplegia or paralysis. But if both lateral and anterior fibers are involved, you get a classical upper motor neuron signs, spasticity, hyperreflexia. Why contralateral? Because this damage occurs before the fibers cross in the medulla decussations. High yield stuff for those vignette questions. Alright, continuing the lineup. The corticobulbar tract, when damaged, it causes trouble with contralateral lower facial muscles and hypoglossal nerve function. Think facial droop or tongue deviation on the opposite side. Finally, the oculomotor nerve fibers. Here, the effect is ipsilateral and mimics a lower motor neuron lesion. You will see oculomotor nerve palsy, partial ptosis with a drooping eyelid, mydriasis with a fixed dilated pupil pointing down and out, and diplopia, double vision, because eye movements is off. This ties back to Weber syndrome signature third nerve palsy. For step 1, connect these lesions to their arteries and symptoms. It's a classic test trap. Alright, let's tackle Claude syndrome, a brainstem stroke syndrome that's a must-know for USMLE Step 1. This condition often stems from posterior cerebral artery stenosis and hits the midbrain, giving us a distinct clinical picture. Picture this, a patient with ipsilateral oculomotor nerve palsy, meaning one eye drooping and out of alignment, paired with the contralateral hemiparesis, ataxia, and hemiplegia affecting the lower face, tongue, and shoulder. That's a lot, right? It's a classical alternating pattern, and Step 1 loves testing these. The major players here are the red nucleus oculomotor nerve and brachium conjunctivum, also called the superior cerebellar peduncle. These structures explain the mix of motor coordination and cranial nerve deficit. For the exam, you will need to pinpoint the lesion site and match symptoms to anatomy. So let's break it down. The oculomotor nerve damage stays on the same side while the contralateral signs like weakness and ataxia tie to the tracts crossing over. High yield, vignette friendly, and a perfect neuroanatomy challenge. Now, let's dig into what causes Claude syndrome and how its structure drives those symptoms. Prime Step 1 material. The root cause is a midbrain infarction, typically from occlusion or stenosis of a posterior cerebral artery branch. This unilateral lesion often nails the red nucleus and cerebellar peduncle, disrupting key pathways. Sounds familiar? It's pretty similar to Benedict syndrome, so watch out for the comparison questions on the exam. Let's map the damage. First, dentatorubral tract fibers. Path of the cerebellar outflow get hit, causing contralateral ataxia. That's your shaky, uncoordinated movement on the opposite side. Next, corticospinal tract fibers. Damage here before they decussate leads to contralateral hemiparesis, weakness across the body. Then corticobulbar tract fibers. These causes contralateral hemiplegia of the lower face, tongue, and shoulder. Think about the facial droop or tongue deviation. Finally, oculomotor nerve fibers. This gives that ipsilateral palsy, drooping eyelid, fixed white pupil pointing down and out, and likely diplopia. Step 1 tip, tie these to the midbrain and posterior cerebral artery and you're golden. Let's shift gears to the paramedian midbrain syndrome, also called a rare posterior circulation stroke and a gem for USMLE Step 1. This syndrome lights up the midbrain and cerebellum with a mix of neurological symptoms that scream, localize the lesion, a classic exam challenge. So what's the deal? It's triggered by the issues in the tegmentum of the midbrain and cerebellum, specifically the median zone. The lesion could be an infarction, hemorrhage, tumor, or even tuberculosis. Variety keeps it interesting, right? The vascular culprits, occlusion of the posterior cerebral artery, or those sneaky paramedian penetrating branches of the basilar artery. This cuts off blood to the critical midbrain real estate, leading to the cascade of deficits. For step 1, you'll need to know the anatomy here. The midbrain's median zone is packed with structures like the oculomotor nerve and cerebellar pathways. It's rare but high yield when it shows up in the vignette, so let's unpack the details next. Now let's zoom into the structures hit by paramedian midbrain syndrome. It is a pure step 1 gold. First up, oculomotor nerve palsy. This is a big one. Damage to the third cranial nerve fibers in the midbrain tegmentums throws the eyeball downwards and outwards. Picture a patient with a droopy eyelid, a fixed pupil. It could be a miosis or mydriasis depending on the lesion, and of course diplopia or double vision because eye alignment is off. The accommodation reflex tanks too, so no focusing up close. Next, contralateral loss of proprioception and vibration sensation. Why is that? The medial lemniscus, carrying those sensory signals, gets knocked out before crossing, so the opposite side feels it. Finally, cerebellar ataxia. Think it this way, it is an involuntary movements and shaky coordination. This ties to damage in cerebellar pathways as well, like the superior cerebellar peduncle, disrupting motor planning. Step 1 loves these triads. Eye issues, sensory loss, ataxia. So connect the lesion to the midbrain tegmentum and posterior circulation and you're all set. Let's explore Perinaud syndrome, a fascinating cluster of eye movement abnormalities and pupil dysfunction, and that is a step 1 favorite. This syndrome pops up when the dorsal midbrain takes a hit, either from direct injury or compression. Picture the mesencephalic tectum, home to the superior colliculus, right next to the oculomotor and Edinger-Westphal nuclei. When ischemia or pressure, like from pineal gland tumor, messes with this area, eye motor function goes haywire. What's the result? You'll see issues like upward gaze paralysis, patients can't look up, plus pupil problems and convergence deficits. For USMLE, this is a localization dream. Dorsal midbrain damage screams Perinaud. It's often tied to masses or stroke, so knowing the anatomy here, the tectum's role in the eye movement and those nuclei that are nearby is the key. Step 1 loves these neurocases, so let's lock this in. Alright, let's wrap up our midbrain journey with Perinaud syndrome, a step 1 classic tied to dorsal midbrain dysfunction. This condition dishes out some standout symptoms you will need to spot in those vignettes. First, paralysis of upward gaze. The superior colliculus in the tectum's hit, so patients can't look up. Downward gaze stays intact, but it's a vertical palsy with a supranuclear twist. Next, pseudo-Argyll-Robertson pupils. The Edinger-Westphal nucleus takes a beating, leading to mid-dilated pupils with light near dissociation. They will react to near objects but not light, plus accommodation paresis. So focusing is off. Then eyelid retraction. Think wide-eyed stares from pretectal damage. Finally, convergence retraction nystagmus. On fast upward gaze attempts, the eyes pull in and retract. Super distinctive. For step 1, link this to pineal tumors or strokes in the dorsal midbrain, master these signs, and you will nail the localization questions. So that's it for our deep dive into Perinaud syndrome and the midbrain. Hope it's boosted your step 1 preparation. If you found this helpful, smash that like button and subscribe for more high-yield breakdowns. Good luck crushing the exams. You've got this.